Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome, everyone. We are genuinely thrilled to have you with us for this deep dive. And when I say you, I'm really speaking directly to you, the surgeons, the anesthetists, the intensivists, and, the ward doctors tuning in today.
Absolutely. The ones right there on the front lines.
Exactly. You're the ones standing at the operating table, rounding on the wards, making those split-second decisions that alter the course of your patients' lives. But before we jump into the material, I do need to share a vital medical disclaimer. This content is for reference only. Always follow local guidelines and institutional protocols in your own clinical practice.
That is exactly right. I mean, we're here to look at the data, synthesize the research, and identify the clinical patterns, but
your clinical judgment is what counts.
Right. Your judgment with the patient actually sitting in front of you is what ultimately matters.
So, what is the mission of today's deep dive? We are unpacking a really pragmatic, perioperative approach to acute kidney injury, or AKI, specifically within the realm of general surgical care. The sources we've gathered provide a complete end-to-end blueprint for navigating this critical complication.
And we really need a solid blueprint.
Yeah.
Because this is an enemy that's hiding in plain sight on almost every single surgical ward.
It really is.
Let's set the stakes right out of the gate so we understand what we're up against. We are talking about an incredibly common, insidious complication. According to the data, AKI happens in up to 20 to 40% of major surgery admissions.
Wow.
Yeah, think about your census right now. Nearly half of your major surgical patients might experience this. And it's not just a temporary blip on a chemistry panel that you can just hydrate away and forget about.
Right.
It is independently tied to increased mortality, drastically longer hospital stays, and a massive risk of progressing to long-term chronic kidney disease.
Looking at those numbers, 20 to 40%, it feels almost inevitable. I mean, are we just supposed to accept that up to half of our major surgical patients are going to suffer kidney damage? Or does the data show a way out of this?
That's the crucial question. And thankfully, there is a way out. The research indicates that around a third of all hospital-acquired AKI episodes are completely preventable with better proactive basic care.
A third.
1/3. That means the protocols, the vigilance, and the physiological strategies we're discussing today, they have the power to fundamentally change the trajectory for a massive portion of your patients.
Okay, let's unpack this. We need to define exactly what we're looking for before we can treat it. The blueprint relies on the KDIGO criteria. That's the Kidney Disease Improving Global Outcomes Guidelines for diagnosis and staging.
Right, the gold standard.
Yeah. So as a quick refresher, AKI is present if you see any of these specific triggers. First, a rise in serum creatinine of 26.5 micromoles per liter or more within a 48-hour window, or a 1.5 times rise above the patient's baseline within 7 days.
And the urine output criteria, too.
Yeah. Yes, and this is the one that requires really meticulous ward tracking urine output dipping below 0.5 milliliters per kilogram per hour for 6 hours or more.
And that staging system matters immensely. It's not just administrative categorization to make the charts look neat. KDIGO stages 1, 2, and 3 correlate directly with mortality risk.
They really do.
They should actively dictate your escalation plans, your ICU referrals, and exactly when you pull in the nephrology team. Stage 1 is that initial 1.5 to 1.9 times baseline bump. Stage 2 is 2.0 to 2.9 times, and Stage 3 is 3 times baseline, or a massive acute rise, or the need for new renal replacement therapy, along with severe anuria.
I was looking at the timeline of post-op care in these sources, and what stood out to me was how the data completely shatters a common clinical myth regarding mild kidney damage. There's a massive aha moment here regarding long-term outcomes.
You're talking about the long-term data on KDIGO stage 1 and 2.
Exactly. Even what we might casually brush off on morning rounds as quote-unquote mild post-op AKI that drastically spikes long-term mortality and the progression to chronic kidney disease.
It's terrifying.
The sources are definitive on this. There is no such thing as a harmless kidney injury. Even a transient reversible hit to the kidneys leaves a lasting microscopic scar on the patient's long-term survival.
Which brings us to the why. Why do our surgical patients get AKI in the first place? The pathophysiology in a complex surgical patient is usually multifactorial, but we can break it down into 3 core pillars to make it digestible.
Let's do it.
First, you have pre-renal causes. This is essentially a supply-side issue, driven by hypovolemia and hypotension. Think about your patients who have been fasting for 12 hours. Add in intraoperative bleeding, massive third spacing of fluids into the tissues, sepsis, or unrecorded losses from a soma or a nasogastric tube.
It's a perfect storm.
Combine all of that volume of depletion with the vasodilation and hypotension from general anesthesia, and the kidneys are simply starved of perfusion.
So using a mechanical analogy, prerenal means the pump isn't priming the filter.
Exactly.
But what happens when the blood flow is perfectly fine, but the kidney tissue itself is under attack?
Right.
What is the second pillar?
The second pillar is intrinsic. This is direct structural damage to the kidney tissue, specifically the tubules or the glomeruli. A major cause here is ischemic acute tubular necrosis.
From that starvation we just talked about.
Right. If that prerenal starvation lasts too long, the tubule cells literally die and slough off. But we also have to look closely at nephrotoxins. This includes non-steroidal anti-inflammatory drugs, your NSAIDs, AC inhibitors, aminoglycoside antibiotics, IV contrast, and certain chemotherapies.
And the muscle breakdown issues too.
Yes, pigment nephropathy, like rhabdomyolysis, where massive muscle breakdown releases myoglobin, causing direct inflammatory and obstructive injury to the renal tubules.
So we have the pump and we have the filter. What is the third pillar?
Postrenal. The plumbing is blocked.
The plumbing.
This includes mechanical obstructions anywhere from the renal pelvis down to the urethra. In surgical patients, we are specifically looking out for pelvic surgery complications, iatrogenic ureteric injuries, massive blood clots in the urinary catheter, or anastomotic leaks that cause a urinoma and external compression.
So we have the pump, the filter, and the plumbing. Any of them can fail, and often multiple are failing at the exact same time in a complex, frail surgical patient.
Almost always multiple.
Which naturally leads us into how we spot the danger before the patient even hits the operating table.
What's fascinating here is how these surgical risk factors interact and compound one another. It's rarely just one thing. First, you assess the patient factors. Older age, clinical frailty, pre-existing chronic kidney disease with an estimated glomerular filtration rate, or eGFR under 60, diabetes, and heart failure.
The baseline vulnerabilities.
Right. Then you layer on the surgical factors. Is this an emergency laparotomy? Is there a massive blood loss expected? Is there raised intra-abdominal pressure like we see in abdominal compartment syndrome?
And then, as if the surgery wasn't enough, we often drop medication traps right on top of those risk factors.
The medication traps are severe, and they are frequently entirely iatrogenic. Beyond the usual suspects of NSAIDs and heavy diuretics, the sources highlight a very specific, dangerous combination vancomycin given alongside piperacillin tazobactam.
That and Zosyn.
Exactly. While both are common, heavy-hitting antibiotics for surgical site infections or sepsis, putting them together creates a synergistic nephrotoxicity. It's a well-documented trap. Add in repeated high-volume iodinated contrast for pre-op CT scans, and the kidneys are taking a massive biochemical beating.
Ouch.
When you mix a frail patient, an emergency laparotomy, and those specific medications, the AKI risk absolutely skyrockets.
Which is why the sources advocate so strongly for implementing the API bundle. This is essentially the preventative armor we put on the patient around the time of surgery to mitigate those compounded risks. Let's look at the pre-op and intra-op phases of this bundle.
Pre-op is all about mitigation.
Pre-op, it is all about identifying those exact risks, documenting the baseline creatinine so you have a true starting point, and stopping the nephrotoxins. Withholding NSAIDs is crucial. You also need to heavily consider withholding ACE inhibitors and ARBs, especially if the patient is at high risk for hypotension, sepsis, or major blood loss during the procedure.
And just as importantly, you have to optimize their volume status before they ever roll into the operating room. You must resuscitate your septic patients and correct that baseline hypotension.
Don't just roll them in unstable.
Never. The surgical guidelines in our sources are explicit. You should avoid taking a hemodynamically unstable patient, specifically someone with a mean arterial pressure or MAP of less than 65 millimeters of mercury, to general anesthesia without a very clear, aggressive resuscitation plan in place.
And once they're actually in the OR, maintaining that MAP target of 65 or higher is your holy grail.
It's non-negotiable.
For patients with long-standing, poorly controlled hypertension or baseline chronic kidney disease, their kidneys are used to a higher driving pressure, so you might even be targeting an MAP of 70 to 75. But the golden rule here is that treating persistent intraoperative hypotension is absolutely critical. Allowing a patient to ride at an MAP of 55 for an hour because they look fine, that is strongly linked to severe post-op AKI.
It absolutely is. And how we choose to treat that hypotension brings us to the science of IV fluids, which is heavily emphasized in this clinical blueprint. The strategy isn't just about restoring volume. It is highly dependent on the type of volume you are infusing.
This is a huge point.
The guidance strongly advocates for using balanced crystalloids like Hartmann's solution or plasmolite, instead of dumping large, unmeasured volumes of 0.9% normal saline into the patient.
This comes down to the hyperchloremic acidosis, right? I think we really need to dig into the mechanism there because 0.9% saline is still universally used. Why is it so dangerous for the kidneys?
It's a critical physiological mechanism to understand. Normal saline has a massive chloride load, 154 millimoles per liter, which is far higher than human plasma.
Right.
When you give large volumes of it, you induce a hyperchloremic metabolic acidosis. The kidney's macula densa senses this extreme chloride delivery and interprets it as excessive salt filtration.
It thinks there's too much pressure.
In response, it triggers tubular-glomerular feedback, which tightly clamps down and vasoconstricts the afferent arteriole. So by giving a fluid designed to improve perfusion, you are paradoxically causing renal vasoconstriction and starving the kidney of blood flow.
That's wild. You're trying to help, but you're choking the filter.
That is why balanced crystalloids are superior. And there is an even stronger warning in the data. You must avoid hydroxyethyl starch solutions entirely. The literature shows they have a direct toxic association with causing AKI and significantly increasing the need for renal replacement therapy.
So the formula in the OR is use balanced crystalloids, utilize dynamic assessments like stroke volume variation and lactate trends to guide resuscitation, and make sure you put in a Foley catheter to accurately target that 0.5 milliliter per kilogram per hour of urine output.
Yes. Avoid hypovolemia and keep the pump primed, but equally avoid excessive, mindless positive fluid balances. Drowning the kidneys and causing venous congestion is just as dangerous as starving them.
Here's where it gets really interesting, the post-op care on the surgical ward. The surgery itself might have been a flawless technical success, but for the patient's physiology, the stress is just peaking. High-risk patients absolutely need their urea and electrolytes, or UNEs, checked within 24 hours of major surgery and again on day 2 or 3.
That early detection window is critical because the surgical ward is completely full of unique, evolving traps. Let's ground this in a clinical scenario.
Sure.
Imagine you're doing rounds on day 2. The patient had a complex bowel resection. They're sitting up in bed, they look relatively comfortable, and their basic vitals are okay. But they have a high-output stoma or an interocutaneous fistula. If you aren't rigorously measuring that exact output, you are missing a silent, massive driver of pre-renal AKI.
The blueprint is very specific on this. These unrecorded losses must be meticulously measured and replaced with matching isotonic fluids, plus the appropriate electrolytes. Under replacement here is a classic, highly preventable error that slowly drains the patient's intravascular volume over 48 hours until their creatinine suddenly spikes.
Then you have the septic abdomens and anastomotic leaks. These are primary driving forces for systemic inflammation, persistent vasoplegic hypotension, and crucially, abdominal compartment syndrome.
Because of the swelling.
When the bowel is inflamed and third-spacing fluid, the intra-abdominal pressure rises. That physical pressure directly compresses the renal veins, obliterating the pressure gradient across the kidney and halting glomerular filtration.
So you have to decompress.
Aggressive source control, like an early relaparotomy for a suspected leak, isn't just a surgical necessity. It's a highly renal protective maneuver.
So sorry for the interruption, but this is important. We need your support to help us grow, reach more surgeons, and keep delivering cutting-edge surgical content. Press the support button and donate now if you like what we do. Let's get back to the podcast.
And what about the physical muscular trauma of the surgery itself? Things like long-duration surgeries, patients stuck in the lithotomy position for 6 hours, or trauma patients with crush injuries.
That is where rhabdomyolysis becomes a major specific risk. Massive muscle breakdown releases large quantities of myoglobin into the bloodstream, which precipitates and is highly toxic to the renal tubules.
The pigment nephropathy.
Right. If you have a patient who is on the table for 8 hours or suffered extremity compartment syndrome, you have to actively check their creatine kinase, or CK levels. If the CK is skyrocketing, you must initiate aggressive, targeted fluid resuscitation to flush the kidneys and carefully manage the resulting, often life-threatening hyperkalemia.
Another trap mentioned in the sources really caught my eye because it is an incredibly common daily dilemma-repeated contrast-enhanced CT scans.
Oh, yes.
You have a patient whose abdominal findings are ambiguous or changing. You desperately need to know what's going on inside to decide if they need to go back to the OR. But every scan is another hit of iodinated contrast to those already struggling kidneys.
It is an incredibly delicate, difficult balance between diagnostic necessity and organ protection. The guidance requires you to weigh the renal risk every single time you order a scan.
Can you just use a non-contrast scan?
Exactly. Can you use a non-contrast scan to answer the clinical question? Is there an alternative imaging modality, like a bedside ultrasound? If the contrast is absolutely essential to identify a bowel ischemia or a life-threatening leak, then you must aggressively optimize their intravascular hydration before and immediately after the scan to dilute the contrast load.
So, despite all our bundles, our balanced crystalloids, and our vigilance, sometimes things still go wrong. Oliguria hits, the urine output drops off a cliff, or the morning labs show the creatinine is rapidly rising. What is the immediate structured workup protocol?
First, formally confirm and stage the AKI using the KDI-GO criteria we discussed. Compare today's number to their true baseline. Second, you must assess their fluid status and peripheral perfusion right there at the bedside.
Look at the patient.
Look at the heart rate and blood pressure trends. Check the jugular venous pressure, the JVP. Look for sacral or peripheral edema. Check their capillary refill time. Draw an arterial blood gas for a lactate level. And if you have the skill, do a bedside echo to assess cardiac contractility and volume status.
And while you're doing that physical clinical assessment, you are simultaneously firing off the necessary investigations. You're sending UNEs, bicarbonate, glucose, lactate, liver function tests, a full blood count, and a C-reactive protein, or CRP level.
Don't forget the urinalysis.
Right. You're doing a rapid urinalysis to look for protein, blood, or muddy brown pus that might indicate acute tubular necrosis. And critically, especially for pelvic, gynecological, or urological cases, you are getting a bladder scan or a formal renal ultrasound to firmly rule out any post-renal mechanical obstruction.
Exactly. You are systematically ruling out the plumbing issues, assessing the pump, and checking the filter. And you're doing all of this while simultaneously searching for the surgical root cause. Is there an anastomotic leak, a hidden intra-abdominal abscess, ongoing occult bleeding, cardiogenic shock from a silent MI?
You're doing two things at once.
You're relentlessly hunting for the root cause while medically supporting the failing organ. If we connect this to the bigger picture of hemodynamics, there's a fascinating, crucial pivot in the management protocols here regarding the use of fluids versus vasopressors.
Oh, this is a huge one. Let's get into this.
This is perhaps one of the most vital clinical pearls in the entire deep dive, and it often goes against our basic medical instincts. Let's say your post-op patient is hypotensive and oliguric. Your first instinct, almost reflexively, is to give a 500 cc fluid bolus.
It's just a reflex.
And if your clinical assessment shows they are truly hypovolemic, you absolutely should give balanced crystalloids in measured boluses, guided by their clinical response. But, and this is a massive but, if the patient is fluid replete, if their venous tank is completely full, but they're still hypotensive,
You do not drown them in more fluids.
you absolutely do not drown them. Pushing more intravenous fluids into a fluid replete, vasoplegic patient leads directly to severe venous congestion. Because the kidneys are encapsulated within a tight fibrous capsule, increased venous pressure translates directly to increased interstitial pressure within the kidney itself.
There's nowhere for it to go.
This eliminates the perfusion gradient and paradoxically worsens the AKI, while simultaneously pushing the patient into acute pulmonary edema. Instead of fluids, you must pivot. You start vasopressors, most commonly norepinephrine, ideally in a high-dependency unit or ICU setting. Restoring the arterial perfusion pressure with pressors, rather than just expanding the venous volume, is exactly the right move when the tank is full.
And what about when all our conservative measures, fluids, and pressors fail? The sources go into great detail about renal replacement therapy, or RRT, which most of us just refer to as dialysis. And I think there is a common clinical misconception that there is a magic-specific creatinine number where you just automatically call the nephrologist and pull the trigger on dialysis.
Wow. If we look closely at the literature, it raises an important question. When do we actually pull the trigger on RRT? The KDI-GO guidelines and recent large-scale trials are very clear that you do not initiate RRT strictly based on an arbitrary creatinine or urea threshold.
Dialysis isn't benign.
It's a highly invasive procedure with its own risks, including hemodynamic instability and bleeding. It is reserved for life-threatening physiological emergencies that are completely refractory to medical management.
The specific hard indications they list are refractory hyperkalemia that won't respond to insulin, dextrose, and binders, severe metabolic acidosis, specifically a pH of 7.15 or lower that you cannot correct medically, refractory pulmonary edema, and massive volume overload where diuretics have failed, or severe uremic complications like uremic encephalopathy or uremic pericarditis.
Right. It's about intervening on life-threatening physiological derangements, not just treating a high lab value on a screen. In fact, the data highlighted in our sources show that jumping to earlier preemptive RRT in the absence of those specific life-threatening indications does not actually improve mortality or long-term kidney recovery compared to a more conservative, watch-and-wait, criteria-based approach.
That is a crucial takeaway that can really change how we manage these patients in the ICU. Escalate early to critical care if the AKI is rapidly worsening, absolutely. But the initiation of the dialysis circuit itself requires those specific, severe triggers. So what does this all mean for the patient when they finally survive the surgery, their kidneys stabilize, their urine output returns, and they are getting ready to be discharged home?
It means the vigilance absolutely cannot stop at the hospital doors. AKI is not over just because the creatinine improved enough to print the discharge papers. Patients who suffer a moderate to severe AKI have a permanently altered physiological baseline. They have a significantly higher risk of cardiovascular disease, future heart attacks, and developing progressive chronic kidney disease later in life.
The guidelines are strict on this follow-up protocol. You must document the AKI episode clearly and prominently in the discharge summary so their primary care doctor is aware. You have to ensure a repeat serum creatinine and eGFR are checked in the outpatient setting, typically at the 3-month mark, to assess for permanent CKD.
And you must educate the patient.
Absolutely. They need to know they had a serious kidney injury, that they must strictly avoid over-the-counter NSAIDs like ibuprofen, and that they need to seek early medical review if they get dehydrated from gastroenteritis or become sick in the future.
Which brings me to a lingering, somewhat provocative thought. It's something not explicitly debated in the surgical text, but it's born directly from looking at this data as a whole.
Okay, let's hear it.
As surgical techniques become more and more advanced, as we push the boundaries of what is operable with massive, prolonged, highly complex procedures, are we sometimes so hyper-focused on the anatomical success of the operation that we inadvertently sacrifice the kidneys in the process? By focusing solely on the immediate surgical victory, getting the tumor out, or fixing the complex anatomy, are we sometimes turning an acute, successful intervention into a chronic, debilitating medical failure for the patient down the line?
Wow. That is an incredibly sobering question to leave our listeners with. The operation was technically a massive success, but the patient ended up tied to a dialysis machine 5 years later. It really underscores why this perioperative blueprint, this proactive AKI bundle, is just as important as the surgical technique itself.
It has to be about the whole patient, every single time. Routine preoperative risk identification, reliable early detection on the wards, and prompt protocol-driven physiological support. That is how you protect the kidneys and secure the true long-term victory for the patient.
That is unbelievably high-yield, practice-changing information today. To you, the listeners, the surgeons, the anesthetists, and the doctors doing this vital, exhausting work every day, thank you for joining us on this deep dive. If you found this medical breakdown valuable and applicable to your practice, please do us a favor. Share it with at least one of your colleagues or friends right now to help spread the word.
These protocols save kidneys, and ultimately they save lives.
They really do. Also, be sure to check out our YouTube and other social media pages for more content. And if you want more actionable clinical insights, dive into our previous season and deep dives, which cover some very relevant, high-yield clinical topics that you encounter every day. Until next time, stay curious and take care of yourselves and your patients.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.